which we use for autism, the characteristic of autism, how common is autism, what causes autism, and how it is diagnosed and associated comorbidities, and various effective treatment approaches for treating it. We will be talking about in my next 1 hour. So let's go back to the history of autism. Autism was first the term used by in 1857 by Eugene Bleuler, a Swiss psychiatrist who coined the term autism and derived this word from the word autos, which means self. But the use of term autism in its current sense was started only 30 years back by an Austrian pediatrician, Hans Asperger. Later on, only in 1943, it was Leo Kanner who used the term autistic disturbance of affective contact in 11 children who had a different kind of behavioral abnormalities where kids were quite self-absorbed. And only in 1990, the ICD-10 included the term pervasive developmental disorder for a group of conditions characterized by qualitative abnormality in social interaction, idiosyncratic pattern of communication, and restricted or stereotyped movements. So in 2000, DSM-4 criteria was given for pervasive developmental disorder. It defined the PDD, which earlier we used to use the term PDD, which has now been abolished, and we just use the term autism, which I'll be discussing. PDD was defined as neurodevelopmental disorder in which there was an impaired social interaction, verbal and non-verbal communication, and restricted and repetitive behavior, which has been modified in the newer version, that is DSM-5. So at present, the main current diagnostic criteria which we use is from the DSM-5, which states that autism is a disorder of persistent deficit in social communication and social interaction across multiple contexts. So it is a persistent, each and every word has a meaning, so be very careful. Is a persistent, ये नहीं है कि अभी मेरा mood नहीं है. It's not a mood. It is a persistent deficit in social interaction and communication. It is not a disorder of speech. Most of the time we get confused with lot of things like कि बच्चा बोल नहीं रहा, ये तो बच्चा बोलता है, ये तो देखता है, ये तो eye contact करता है. No, it is a deficit in social communication and social interaction across multiple contexts. There is a restricted and repetitive pattern of behavior and interest or activities. This, very importantly, the symptom must be present in the early developmental period. There is no cutoff. Earlier, there used to be a cutoff age, but now there is no cutoff. And in fact, it has been seen that as the age increases, age of the child increases, the social demand increases, and social demand exceeds the limited capacity, which may be masked by the learned strategies in later life. So it becomes more and more manifest as the age of the child increases. So earlier we never used to see children at later age group, but these days we are picking kids also at 6 years, 8 years. Right now I had a child who was 8 years and has come with the problem that is not studying, but actually he has an autism spectrum disorder. Symptoms must cause clinically significant impairment in social, occupational, and other important areas of current functioning. So a child has to be labeled disability only when there is a functional impairment, very important. And then these disturbances are not explained by intellectual disability or global developmental delay. So this is a comparison which you should be just aware of it. You don't have to go into the detail of this, but yes, I will be just highlighting the main points which has been different from the previous version of autism, which were given in DSM-4, in which the PDD used to be various categories. You must have heard the name of Asperger's and childhood disintegrated disorder. But the latest version, that is DSM-4, says it is everything comes under the one category of autism spectrum disorder, There are no diagnostic subcategories, reflecting that there is a lack of reliability across clinician in assigning subcategories. So they have abolished the subcategories. And so now there is no more term like Asperger's disorder. Then comes the, for diagnosis purposes, you require two categories, category A and category B. In category A, there is a persistent deficit in social communication and social interaction across multiple contexts. Try to understand what is social communication. Social communication is a deficit in social emotional reciprocity, which may range from, example, abnormal social approach to failure to form normal back and forth conversation. You will see a lot of children who are speaking. It is not that autism children does not speak. They can speak, but they lack normal back and forth conversation. They do not have conversational skills, to and fro kind of a thing. There is a reduced sharing of interest or emotions, failure to initiate or respond to social interaction. So as we know, every disease has a mild to severe category. So there can be milder version where child can speak, but child does not initiate or sustain the conversation. And there can be, second point is deficit in non-verbal communicative behaviors like social interaction, poor engagement, and there is lack of facial expression, non-verbal communication. I will not go into the much details because of lack of time. I will just tell you the important points that social communication and social interaction has been combined in one category. Earlier, in previous DSM-4, social interaction was a separate category and communication was a separate category. But now they have learned that it is the social communication, it is not the speech which is affected. It is specified that social communication interaction deficit must be manifested across multiple contexts. I am again and again stressing on the social communication because most of the time we do not understand the term social communication, which is different from the language or the speech. In DSM-5, language impairment is not included in the diagnostic criteria, very categorical, not included. And there is an impaired and its stereotypic language is considered as an aspect of restricted activities. There can be echolalia, which comes under the category of part B, which says there is a restricted and repetitive pattern of behavior in the form of motor activities like simple motor stereotypic lining up of objects, echolalia, or idiosyncratic phrases. There can be instances of sameness. There is inflexible adherence to the routine. रोज एक ही काम करना है, वैसे ही होना चाहिए. अगर कुछ भी change होता है, तो वो upset हो जाता है. So this, when these kind of behavior causes distress in a child or it affects learning of a child, it has to be taken as a symptom of autism. There can be hyper or hyporeactivity to the sensory input, that is sensory issues. What does it mean by sensory? Body में 5 senses हैं, जैसे auditory, tactile, visual. So there can be hypersensitivity, there can be allergic reaction. They do not like the touch, they do not like the light, or they do not like get upset with certain sounds like cooker, whistle and all. Or there can be hyposensitivity. Okay? Normal, they need more, there is a need for more sensory input in the form of touch, in the form of visual input, visual stimuli. So all these can be a features of restricted and repetitive activities of autism. As age of onset, I have already described. In earlier, we used to say that it has to be up to, symptom has to be present before 3 years. Now there is no age limit. That means we are picking up the cases even at a later age group, because symptoms may be present in the early phase but does not manifest till the time the capacity to the capacity of the child does not, the social demand does not exceed the child's capacity. So it can be present in the later age groups like 6 years, 8 years. And then the symptom must also cause impairment in the social, occupational, or other important areas of the current functioning. This can be presented in the form of 3 levels. Level 1 is when the child requires support. Level 2 is when child requires substantial support. And level 3 is when the child requires very substantial support. So it indicates the effect of disability on the day-to-day activities of the child's life. If the severity is more, definitely the prognosis is not that good. Then in DSM-5, social communication disorder. Asperger's, you people must have heard about Asperger's, जो पहले होता था DSM-4 में. Now that term has been abolished, but there is another term called social communication disorder, which is a new term in which the child does not fulfill all the criteria of autism, but has social communication disorder only. Then we label the child as a social communication, SCD, or social communication disorder. Asperger is not used anymore. Then comorbidities. Previously, if a child had autism, we would not label the child as hyperactive or any other movement disorder. But now, as we have learned that autism is just a disorder of social communication and restricted activities, these children can have hyperactivity, or ADHD can be diagnosed along with it, and other movement disorders can also be diagnosed along with the autism spectrum disorder. As we have already discussed, the prevalence is increasing, and the Autism and Disability Diagnostic Monitoring Network has shown that the prevalence has been increasing in Western countries. In 2000, it was 1 in 150, which has increased to 2010 by 1 in 68. And in 2018, in 1 in 59, whereas I was reading the latest literature by the CDC, which has documented up to the level of 1 in 44. So we can imagine the extent of burden on the society, the way it is increasing. And in the latest studies from India has also shown the prevalence of almost 1 in 100. So all of us must gear up and be prepared to identify these children as early as possible so that the early intervention can improve the outcome of these children. So let's understand why there is an increased prevalence. Is it just the broadening of the diagnostic criteria? But studies have shown it is not just the diagnostic criteria, it is also there is an increased public awareness. People are now more and more aware about this disorder. These days I see in my practice people read the literature on Google, and when they find something, the child is not making eye contact and they find this kind of terminology, they come on their own. Even pediatricians are not sending, they are coming to the developmental pediatrician directly also. So, and secondly, there is a recommendation of universal screening. So, according to the American Academy of Pediatrics, almost all the children at 18 months of age should be screened for the autism spectrum disorder by using MChat, which in India also we are trying to promote so that as we can pick up these children as early as possible. As we know, first 3 years is a very important time for the developmental point of view. There is a neuroplasticity, and if we pick up these children early, we can help these children with the early intervention. Then, as there is an increased availability of early intervention plus diagnostic substitution, that means, as I said, that earlier, if the child was diagnosed with autism, ADHD was ruled out, or vice versa. But now we can give the diagnosis of autism with ADHD and otherwise also. Then let's see how can we detect autism early. The first word project from the Florida State University was gave the relevant information to guide clinician how to identify autism by giving red flag signs or ASD. According to them, they insisted that there is not a single pathognomic symptom that guarantees the presence of autism spectrum disorder. Not all children with autism show all and every one of the symptom all the time. And this should prevent the clinician from using by saying, this was normally we have a tendency, we tell this child does not have autism because I saw him looking at the eyes of other. वो eye contact कर रहा था, वो बोल रहा था, तो इसको autism नहीं हो सकता. There is nothing like that. Autism children can give eye contact, but majorly for a need-based communication, not for the social communication. Then, according to American Academy of Pediatrics, what are the red flag signs of autism spectrum disorder is that there is lack of showing. They generally do not point at the objects. They have lack of coordinated verbal and non-verbal communication. Normally by 1 year of age, child start pointing objects. अगर आप उससे पूछो पंखा कहाँ है, मम्मा कहाँ है, so they start pointing with their index finger. So these children does not point out. They lack appropriate gaze. अगर आप उनको ऊपर कुछ दिखाने की कोशिश करो, like बेटा ऊपर देखो, like चंदा मामा or moon or aeroplane, you know, they will not follow the appropriate gaze. And there is lack of response to name, which generally comes by 6 to 7 months. This is one of the commonest symptom which we see in our practice, that parents कहेंगे कि ये बोल तो रहा है पर ये अपने नाम को नहीं respond करता. So all these things should, you know, raise your antennas. Lack of warm and joyful expression and repetitive movements or posturing. कोई एक ही activity बार बार कर रहे हैं. Lack of pointing, as I said. अब lack of pointing is also 2-3 types which I'll not discuss. But बच्चा अगर कुछ sometimes वो कहेंगे कि point कर रहा होता है, but that's meaningless. ऐसे अगर सिर्फ उंगली से कर रहा है, but it has to be a, if he is showing something of his interest, I want this, or wo dekho wo kya hai, that is pointing. And lack of playing with the variety of toys, lack of response to contextual cues, and lack of communicative vocalization. All these, if a child at 1.5 years not speaking any word meaningfully, or by 2 years not speaking 2 words meaningfully, that also should be taken as a red flag sign. So before going on into the etiology of autism, I will talk about the common myths in the society. कि बच्चा नहीं बोल रहा, कोई बात नहीं, लड़के तो लेट ही बोलते हैं. So it is a myth. There is no literature supports that the boys speak later. So another myth is that during pandemic my child has watched lot of TV. 8 से 10 घंटे उन्होंने TV देखा है, तो उसकी वजह से वो बच्चा बात नहीं कर रहा. No, that is also not a reason for autism. It is the children who are watching excessive screen or who are addicted to screen. They may have behavioral problems or neurodevelopmental issues in the form that they have lack of attention, but it does not cause feature suggestive of autism. Then generally parents are often blamed कि आपने उसको ध्यान नहीं दिया है, इसीलिए बच्चे को ऐसी प्रॉब्लम हो गई है. No, parenting, it has nothing to do with the bad parenting skills. Autism is a neurodevelopmental disorder. And another myth is like everyone with autism is not speaking. Speaking is a separate entity. Sometimes autistic children can have language impairment, associated comorbidity, but it is not necessary. So make sure that try to understand the autism is a disorder of social communication. The communication used for the social purposes is called social communication. And they often see speech therapy. We have seen generally, especially in busy practice, कि अच्छा बच्चा बोल नहीं रहा, speech therapy के पास जाओ या exercise करा दो, OT के पास चले जाओ. It should not be the way of handling these children. Any child who is not speaking or not responding to name, and you have done MChat for that child and you feel there is a high suspicion of autism, should be referred to the neurodevelopmental pediatrician for detailed evaluation. Then common important myth is vaccine. आपके लोग बस बहुत आते होंगे कि वैक्सीन नहीं लगवा रहे, ऑटिज्म, मेरे पहले बच्चे को ऑटिज्म है या ऑटिज्म हो जाएगा. There is no correlation with the autism. So all children should be motivated that they should get their vaccination complete. Then we are speaking a lot of, especially in metros, we are speaking a lot of multiple languages at home, Malayalam, English, and Hindi. So that's why my child is not speaking. So literature has, according to literature, there is no correlation with the multiple languages. In fact, we encourage children who is not speaking to speak one language, but that is not the reason for the development of autism. Then what are the reasons? Although exact etiology is not known, but yes, it has been seen that genetic factors plus environmental factors, it's a multifactorial kind of a thing where which can lead to the autistic outcome. And in genetic factors, we have seen that in twin families, the families where twins are born, or in a lot of families, we have seen that there is a proband. So if it is 50 to 200 times more prevalent in the sibling of autistic proband than in the general population. So there is some genetic predisposition in these children which gets manifested in the presence of environmental factors, although exact reason we do not know. Then concordance rates of autism also have shown that in monozygotic twins, almost 36 to 96% have higher chances of having autism, and in dizygotic twins, it is 0 to 27%. And which has been proved by a lot of gene screening and cytogenetics, and multiple genes, multiple chromosomes has been identified in the form of chromosome 2, 3, 4, 6, 7, 10, 15, 17, and 22, but no single gene has been implicated till date. And so future direction for genetic research in autism lies in identifying specific gene environment interaction. Then what are the other risk factors which has been documented according to the various researches is that if there is a presence of intellectual disability, there is a 8 to 27% higher chance. There is Fragile X syndrome, 24 to 60% higher chance of developing autism, tuberous sclerosis, and 36 to 79%, neonatal encephalopathy, cerebral palsy, Down syndrome. We see a lot of children with the Down syndrome and Williams and other genetic disorders. So there is a two types of autism we generally classify. One is syndromic and one is non-syndromic. So in syndromic children also, we have to have a very high index of suspicion for the autistic behaviors. Then muscular dystrophy, we have seen a lot of children who have muscular dystrophy and they come with the toe walking. We consider it as a part of the autistic spectrum disorder, but that could be because of the underlying muscular dystrophy. So if there is a child who has autism plus toe walking and you think there is any sign of muscular dystrophy, kindly check the CPK at least. And neurofibromatosis is also, we see 4 to 8% chances of having autistic behaviors. Then what are the environmental risk factors? The environmental risk factors are advanced parental age is one of the most important environmental factors which has been implicated in most of the studies. Along with that, there are other things like exposure to medication, interpregnancy interval, short pregnancy interval, multiple gestation, maternal obesity, gestational bleeding, infections, and perinatal factors. So a lot of factors have been there which increases the chances of autism behavior. Then there are as we said, there is a neurodevelopmental disorder. So there is a neuroanatomic and neuroimaging findings which we can discuss, that it has shown that there is an increased cerebral volume that affects both gray and white matter as well as the enlarged ventricles. And there is a clear difference in the function and structure of empathy circuit of the brain, like amygdala, ventromedial prefrontal cortex, temporoparietal junction, orbitofrontal cortex, anterior cingulate, and other related regions. There are also differences in the connectivity between frontal and parietal lobe function that are thought to relate to the cognitive style. As far as the biomarkers are concerned, till date, there is not even a single biomarker which identifies the development of an autistic behavior there are a lot of studies going on. One of the study implicated that early brain growth, where it was seen that children had a increased head size till 2 years of age, and then it becomes at par with other children. So, but still it has not been taken as a important biomarker. Other things which has been implicated is neuroimaging pattern on fMRI, electrophysiologic changes, and measurement of the eye gazes. We hope that we get a biomarker in near future. Then clinical aspects, why this happened. So there are no exact reason is known, but various theories has been implicated about the impairment in social interaction. One of them, the most important, is theory of mind, which you must have heard that there's an impairment that negatively affects pretend play, empathy, sharing, social and emotional reciprocity, and peer relationship. Theory of mind impairment can be seen in all individuals with autism spectrum disorder, regardless of the age and intelligence. Then stimulus over selectivity. This is due to the restricted attention or bias towards the known, global, and local information. These children generally has a very focused attention. They focus on a very specific thing. So this is called weak central coherence theory. Enhanced perceptual functional theory. One of the most important findings in recent years has been the observation of 2-year-old with autism fails to orient towards the biological motion. That is, the human body is in motion. And that they do not preferentially look into the eyes of the approaching adults. And this is what is lacking, social interaction and social communication. So children with autism spectrum disorder showed several atypical behaviors due to sensory hypersensitivity. As I discussed, there are sensory issues present, but this is just a theory. It is not only always hypersensitivity, there can be hyposensitivity also. Auditory and tactile hypersensitivity can be stressful for these children. That leads to, so we do not have an exact reason anyway. Then let's talk about the diagnosis. Once the presence of autism spectrum disorder is suspected, the child should be referred to a multidisciplinary assessment in which all the members of the team should have some training in the diagnosing of autism spectrum disorder, and at least one member should be trained in the assessment and diagnosis using the standardized instrument. What are the standardized instrument? DSM-5 criteria is used as the criteria to diagnose autism, but to see the severity of autism, there are various tools available in the forms of childhood autism rating scale, Incline tool for autism spectrum disorder, you must have heard of that. Then ADIR, autism diagnostic interview, and ADOS. These are the gold standard used world over to diagnose autism. So in India, very few people are using and has been trained. I'm trained for all these tests. So, but it is not clinically and practically possible in our day-to-day practice where we have a huge burden of patients. So we prefer to use childhood autism rating scale or Incline tool of, and then there is an ISA, which is also Indian tool to assess the autism. Then guidelines, including the detailed inquiry, is done into the specific concerns raised by the family and teachers regarding their medical history, home life, education and social care, and all the behavioral issues. Beyond the diagnosis of ASD, a diagnostic assessment should also be done to see the profile of strength, need, skills, and impairment. Where is it? What are the strengths and weaknesses of a child? That is also very, very important. That is important from the management point of view. Then comes the co-occurring conditions. We very often see comorbidities in these children in the form of sleep disorders. It is seen in 50 to 80% of the children and can be corrected with the ferritin. If the ferritin levels are low, can be corrected. Sleep hygiene can be corrected. Good sleep hygiene measures can be told to the parents. And if does not work, then melatonin can be supplemented in these children. Then comes the seizures, which is seen in almost 7 to 23% of the children. The highest risk factor for for a child of autism to have seizure is the associated intellectual disability, if the child is female or if there is a lower gestational age. Then feeding difficulties are also quite common. We see feeding difficulties, one because of pica, because they tend to put everything to mouth, or because of the sensory issues in the form of they have a preference for specific texture or temperature. The common GI symptoms which are seen in these children are constipation is one of the commonest problem which we see in these patients, and which does have an impact on the behaviors, like they have abnormal behavior during when the child has constipations. Then other associated neurobehavioral disorder commonly seen with them is ADHD, anxiety, mood disorder, and aggression. Very commonly in practice, you must have seen बच्चा बड़ा hyperactive लग रहा होता है. ये तो hyperactive है, autism नहीं है तो hyperactive है, but actually he has an autism and has been labeled by a journal practitioner or journal pediatrician as a ADHD. So let's not label in our day-to-day practice. We just suspect that these are the areas of concern, and let's have the detailed evaluation before labeling a child. So then comes the wandering. Wandering is the most common cause of morbidity and mortality in these children. That means they tend to run away from the home, or they elope, or they drown. They are prone for accident. They do not understand the implications. So it is very important to prevent these children from wandering, and for that, make the environment of the house safe. And there are gadgets available which can track these children. So there are watches with the GPS which can be given so that these children can be tracked also. Then comes the investigation. What are the investigation routinely should be done in a child who has an autism spectrum disorder? So routinely metabolic testing should not be done. But there are children who have associated problem, like we had a child who has an amino acid problem, and we diagnosed and we treated that child and had shown improvement. So in treatable causes, yes, it can be done, but routine metabolic testing is not required, and routine MRI should also not be done. Hearing can be done to rule out any hearing impairment for sure. The main indication for MRI are if there is any associated microcephaly or macrocephaly in these children, there is any atypical regression, presence of seizures, intracranial manifestations of genetic disorders, or abnormal neurological examination. All those features indicate that these children should be investigated by an MRI. Then comes the genetic testing. Genetic evaluation should be recommended to all the families as a part of etiology work. Very, very important. Deceleration in head growth velocity in a girl child with the midline movement when we suspect Rett syndrome. MEG-P2 is the specific gene which we can check. If there is a marked macrocephaly with pigmented macule on the penis, then PTN gene is one which can be tested. So there are a lot of genetic testing available in these children. And in fact, studies have shown that with the help of chromosomal microarray, almost 5 to 12% of the cases can be picked up, and definitive diagnosis can be made in almost 17 to 40% of the children. So it is very important that we try to find out why this is happening to the child, and especially for the future pregnancy. Then Fragile X screen is the important screen and should be done in all the boys and family, if especially there is a family history of family member having a intellectual disability. Currently, the data shows almost 0.45% of the autistic spectrum disorder cases show full-blown Fragile X syndrome. And if required, whole exome sequencing can be done in these children, depending on the clinical picture. Then what is the prognosis and outcome of these children? It has been seen that children who has a comorbid intellectual disability generally have a poorer outcome. Children who have language impairment and who are diagnosed or a severe severe autism have a poorer outcome. More than 80% who are diagnosed with autism spectrum disorder after evaluation at less than 3 years generally retains the diagnosis. It is the average or above average cognitive abilities with milder symptoms are difficult to diagnose before 3 years. So children who are picked up generally after 3 years are the milder variants. Let's understand. That's why they are not picked up in the first 3 years. So generally, children who are coming at later ages are the milder variant and have a better outcome. It has been seen that 9% of the children who are diagnosed in early childhood may not meet the criteria later on. That means they can outgrow this problem. So as we used to think that there is no cure, and first important thing, let's understand this is not a disease. Autism is not a disease. It is a condition in which the child has a different ways of learning. So we have to teach the way he learns. So when the parent says कि कब ठीक हो जाएगा, कितना time लगेगा, we do not have a idea. We don't say the time frame. We say it is a condition. If the functional improvement occurs, child will definitely improve with the intervention. So the quality of life can be improved when adequate programs are available in the community and can be provided to the patients. Then let's come to the treatment. Most of the time we are very confused. कैसे treat करना क्या autism का, and we will refer to OT के पास भेज दो, speech के पास भेज दो. As I said, this is a multidisciplinary team. First important is to diagnose, then do the evaluation and make the therapy plan. The only, as you can see in the chart, the lowest column says the only treatment which has been supported by evidence is the behavioral intervention, and rest of the therapies are weekly recommended or not recommended, like all these gluten-free, casein-free, secretin, chelation, immunotherapy. You must have come across a lot of sensory, and all these diets are weekly supported by the evidence. They are not fully supported. The only treatment which we do is the behavioral intervention or behavioral modification, which we commonly say. And risperidone is the medication which can be given for the challenging behaviors if the child has a difficulty in sitting down and following the commands. Then programs involving behaviorally based interventions to improve parent-child interactions are the main emphasis should be on the social communication part, and diagnosis has to be by the multidisciplinary team, as I have already discussed. So beware of the false or misleading claims for treating autism, which is very common in these disorders. You must have heard of hyperbaric oxygen chelation therapy, stem cell, and so there is a big no to all these therapies. So the carry home message is, as a pediatrician, your role is to identify the symptoms of autism spectrum disorder in early childhood and support the family through the process of diagnosis and intervention, address the etiologic evaluation, engage in shared decision making. It is very important. Pediatrician should coordinate with the developmental team or the developmental pediatrician so that there is a decision making becomes easy for the patient, and help in managing the co-occurring medical conditions and comorbidities, and diagnosis and management has to be done by the multidisciplinary team. Thank you so much. Thanks for the kind attention. Yeah, thank you.
Thank you, Dr. Praveen. Suman, and you have spoke very well and excellent presentation. I think you highlighted each and every point, how to diagnose, what are the early markers for diagnosis of autism, and what are the diagnostic tools for diagnosis of autism. Let me tell you one thing, that we are seeing a lot of cases of autism nowadays, and you have shown that incidence has increased, prevalence has increased from 500 to 1 to 59 nowadays. So
1
it has
to
increased
144.
tremendously up to
44,
144.
almost 40.
Yeah.
Yeah.
So on 44th, it's tremendously increased. And if the parents concerned regarding the persistent inconsistent hearing or unusual responsiveness, if features are there, are extremes of temperament or behavioral, like patient presenting with marked irritability, so these features are there, you can diagnose that this patient may be suffering with autism, this child may be suffering with autism, and you can immediately send to the developmental pediatrician. And what we are using here, the tools are mainly the Indian scale for assessment of autism, or sometimes incline scale or CARS scoring. We are not using the diagnostic interview scale here in our setup. And regarding the treatment, as you mentioned, that there is no treatment. Yes, there is no treatment, and only behavior intervention is the only therapy. Sometimes we are using for hyperactivity. We can use, if there is hyperactivity, you can use some methylphenidate-like thing, or risperidone is the for the behavior, as you mentioned. So these are the few therapies which we should remember, and I think pediatrician should be aware of regarding the earliest symptom, so that they can diagnose the autism and they can refer it to the developmental pediatrician. So thank you very much, Dr. Praveen, for highlighting each and every point in an excellent way.
Sir, I want
Yes,
to add
Dr.
one
Praveen.
point.
Please respond.
I didn't say there is no treatment. I said there is a treatment available, only treatment available and
Yes, very
evidence
good.
supported is
Yeah,
behavior
that's
modification. That's a treatment and children. There is a significant treatment.
Thank you, Dr. Praveen. Thank you very much. Before we are going to questions, that let me clarify. Dr. Praveen also said that there is only behavioral therapy, and come out of the myth of the desperation of the patient. People are exploiting them because of desperation of parents of these therapies. And risperidone is required in the rarest of the rare cases. So risperidone is not the medicine. Dr. Praveen has clear-cut said. It is only for the complication of the psychotic problem they will have. So risperidone is not the drug for autism. Autism is only core problem is only solved by the behavioral therapies. So thank you very much, Dr. Praveen. Dr. Baljit Singh wants to know more on MChat, and he also asked about the what age the medicine can be started.
So that's a very good question, Dr. MChat, in fact, in near future, we can have one class on, if Dr. Alka would like, then we can have one class on MChat, because I think that is the need or the hour that all the pediatricians should be well versed with the autism spectrum and MChat screen, because most of the parents are already anyway, they know most of the things. So in MChat, there are 20 questions given, which is available in Hindi as well as in English. Or the questions are in the format of yes, no. Parents ko answer karna hai, yes, no questions. And there are scoring available if the child has failed on those scores. So if the score is less than 2, that means child is low risk. If the score is between 2 to 8, it is a moderate risk. And if the score is more than 8, definitely the child has to be immediately referred for the detailed evaluation. So if we can do those screening for all our children, if we make it mandatory कि 18 महीने पे जब भी 1.5 साल वाला आपके पास में वो immunization के लिए आ रहे हैं DPT के लिए, then that time you give that chart to each and every child. It hardly takes 2 minutes, 2 to 3 minutes to fill that chart, and we can pick these children early. But remember, this is not a diagnostic tool. Please do not label the child autism on the basis of MChat. You will just see that this child is likely to develop developmental disorder. So kindly consult the developmental team, whatever, wherever you want to send. So that is very important. The child has to undergo, like I'm a developmental pediatrician. When a parent come to me, I see the child for 1 hour. Despite that, I do not label the child. I tell them I am suspecting autism. I will do the detailed evaluation, then I will label. Please understand the parent psychology. It is very difficult for them to take a label which is going to be a lifelong, just like that is not right. So, पहली बार में हम कभी भी autism ऐसे नहीं बोलेंगे. just make them aware that there are certain disorders like autism. आप check करा लो. That's very important.
Dr. Praveen, there are a few more things you have made the difficult topic very simple. Can you share the presentation again, one couple of slides that may be helpful?
Yeah. Which one?
Yes.
Which one you want, sir?
So slide number 3 or 4, where you compared the DSM-4 and 5.
Okay. Okay.
Can you share that?
Yeah.
So
Sure.
the question on that, yes, I will come on that slide. Overall, what I could gather, you very well said that it is not a disease. Second thing, you also said it is not uncommon. It is very common, and up to 20-25% of the patients can come with, say, developmental or behavioral disorder. So this is one of the commonest complaints of behavioral disorder. One of them is autism incidence, which you said. So here I want to comment on Rett syndrome and CDD. Here they are not included in this also, ASD also. And rats, you said later on that it is a genetic diagnosis with monogenic. So the things 1 to 3 here you have clearly indicated that they are in the ASD. But Rett syndrome and CDD are different. They are removed from the ASD. Right.
Everything comes under ASD, sir. Now
no,
everything is
not 4 and 5.
Yeah, 4 and 5 also. 4 and 5 is a genetic disorder. Yes.
Yes. So they are not in the ASD. They are removed from the ASD spectrum. I understood this. So explanation on this. Just I wanted clarification. 4 and 5 are they removed from ASD separately. So there was some slight confusion. Second thing, the incidence 1 in 68. You said incidence 1 in 68. So in one case, you mentioned that it's at 7 years or 8 years child came with the disorder. So if this prevalence is at the age of 7 or 8 years, I think. But what age this is the incidence? At age
this
1,
is not
2,
an incidence. This is a prevalence. I'm not talking about.
Yes,
I'm not talking about. Sir, I'm not talking about an incidence of these children. I'm talking about the prevalence in the society. Prevalence. This is done by the. This is a US data from the. So they have the diagnostic criteria. It can be picked up at any age. Generally. So you do not. There is no cutoff like that.
Right.
Okay. Right. After 6 years, you cannot have autism. After 7 years, you cannot. Early, if you will see the previous slide, like this slide, I'll just show you. Just give me 1 minute. In this slide, you can see age of onset. Earlier, we used to think that delay or abnormal functioning in at least 3 of the behavior must be present prior to age of 3 years. Okay. So there used to be categorically, they used to say that symptoms has to be present before 3 years of age. Then only we can see a child, we can label a child as autism. I'll tell you, like right now, before starting the presentation, I had seen a child who has come with the complaint that child is not doing academically fine. He is now class 7, he's 7 to 8 years of age, and he is in class UKG or whatever. So he is not doing well because parents are thinking that he's not studying well. But when I go back to the history, I ask the history, the child started speaking late. He does not make friends. When he's talking to me, he's not making an eye contact. He's not giving an appropriate social interaction. So you have to look into the cause of poor school performance as autism, not as a learning disability or as an IQ. So this child has presented at 7 years because now earlier he was in milder case, and he was able to cope up with his limited capacity. Now the social demand has increased in terms of academics, in terms of he has to go and make friends. So now he's not been able to cope up. So now it is manifested in at
well
this
explained,
age.
madam. Very well explained.
I hope you understand.
Yes, I got it.
Okay.
Madam, one more explanation. You said that in a sibling, it is 50 to 200 times more than the general population. When it translates to percentage in the siblings, so in the next sibling, it comes to 10 to 20%?
Yeah, it is like what we say is, if a parent has a one child with autism, the second child having autism becomes 10%.
Right,
And if
right.
they have
Okay.
2 children with autism, then it becomes 30% chance of having
Okay.
the third child.
Okay.
That is
So,
how.
so
Yeah.
that becomes 50 to 200 times more than the general
Yeah.
population. Right. And there are 2 questions in the chat box. Dr. Ritu wanted to ask any side effect of long-term risperidone. So I would say, first of all, we should remove the focus on chemotherapy. Then Dr. Praveen, please go ahead.
Yeah. As Dr. Sanjay said very well, that risperidone is not the first line of treatment for these children. It is given just for managing the challenging behaviors and difficult behaviors along with the behavioral therapies. Definitely any drug for that matter for long term we try to avoid, especially in children. And in fact, I would tell you in my practice, it is the most difficult to convince the parent to start a medication. आप 3 साल की 4 साल के बच्चे के parent को अगर आप कोई neurological दवाई के लिए बोल रहे हो, it is not easy for them to accept and start it. So unless parents are in, too much of distress, they will not start the medication. And if the child is settled on those medication initially, after some time, definitely we would, if it is because of ADHD, we would like to go to the medications of ADHD rather just on the continuing risperidone for a long time, or change the medication as and when required. And you have to monitor the renal function and liver function test and all those stuff, so that to look for any side effects if you are continuing it for a long-term purposes.
Dr. JP Tandon is asking what do you do in behavioral modification? I think that will need another session, but still, if you can respond.
Okay, yeah, sure. So behavior modification is the most important treatment in this. Like as I said, the child, let's understand simply. मैं आपको बताती हूँ autism क्या है. बच्चा intelligent है, सुन रहा है, बोल रहा है, अपनी मर्जी की सब चीज कर रहा है. बस वो so the basis is that he is doing everything in which he is interested. जिस चीज में उसका अपना इंटरेस्ट होता है वो सब कर रहा है. Plus he is generally a good visual learner. So if we teach these skills through things which are of their interest, this is called reinforcement. So एक टेक्निक होती है. फॉर सिंपल मैं आपको एग्जांपल देती हूँ. उसको चिप्स पसंद है या चॉकलेट पसंद है, आप उसको बुलाओ चॉकलेट, वो आपको देखेगा. So this is a simple technique. By doing this, you can tell the child to make an eye contact, and फिर उसमें आप face pairing. There are techniques available. आप बच्चे को social interaction सिखाते हो. अगर उसको अपने से ज्यादा motivation आप में मिलेगा, he will look at you. This is called behavior modification, and every behavior has a consequence. So you change the consequence or the antecedent, तो वो behavior उसका change हो जाएगा. So these are the basic principles on which we work. We make the individualized plan for each child. It is not कि हर एक को एक ही काम करेगा. हर बच्चे का अलग plan बनेगा, अलग तरीके से काम होएगा. इसलिए असेसमेंट जरूरी होता है. असेस करके आपने उसका प्लान बनाया, उसको इम्प्लीमेंट करके बेस्ट इज टू ट्रेन द पेरेंट्स, because parents are with the child most of the time and they can work with the child at least 5 to 6 hours per day. If they work, we have generally seen a very good results in our practice, and kids are picking up very, very well. So this is not speech therapy. This is different from speech therapy. We are not telling them to speak. We are telling them to look at us, to make an eye contact, so that they understand that उनको हमारे को देखने से फायदा है. वो देखेंगे, हम उनको reinforce करेंगे, धीरे धीरे उसका eye contact build up करेंगे, फिर इसको सिखाना शुरू करेंगे. Pointing, एक एक चीज, like you have to teach them skills. Pointing, normally you don't teach a child all these skills, isn't it? बच्चे को देखना कौन सिखाता है, pointing कौन सिखाता है? But this is our job now. Teach each and every skill to the child.
So we can reward the good behaviors, and
yes, we can
they will help them forget the unwanted behaviors. They can be unlearned.
Yes, they can.
The behaviors which are not wanted, they can be unlearned like this.
Yes.
Okay. So Dr. Ritu again wants to ask, please summarize the environmental factors.
Sorry, क्या?
Please summarize the environmental factors.
Acha, you want me to show this slide? I'll go back.
It's okay. You can summarize them.
Acha, summarize in the sense, as I said, the most important is the advanced paternal age. This lot of studies I've seen that advanced paternal age is very, very important. parental, in fact, both parental and father's age is also equally important. And then any medication, prematurity, any risk factor, perinatal risk factors, any radiations, any all these factors are very, very important. Age is the most important, I would say, is the age.
Right, Dr. Praveen, because there was, as you showed, say, functional MRI, there have been studies in the siblings of the sufferers, right from the neonatal functional MRI, showing that functions in different areas like amygdala, you said, and they were followed up. So still the results are not very, but siblings are being studied at that level. So before I give more questions, I would say very well said. It is more of not a disease. It is not uncommon, as you said very well. It is not just a checklist. It is a diagnosis which with the clinical grounds, a checklist, as well as there can be mild, moderate, severe, and all three domains of social communication, social interaction, and social behavior. There can be mild, moderate, and severe differences. So the people who are having good intelligence, they are likely to recover better. Who are having less intelligence, so this also varies. All are not having good IQ, all are not having bad IQ. So there can be variable things. So we can predict who is going to improve, I think.
Yeah.
Is it right, Dr. Praveen?
Yeah, yeah,
So
yeah.
we can
So at
select
least
the
we can
cases, we can have a prognosis.
I can give you the 4 important prognostic factors. One is the age. Second is the IQ of a child. Third is the severity. And fourth, if the child is verbal. So if we see these 4 prognostic factors, we can prognosticate them.
Yes, but more in the most of the centers, we are not doing IQ, but some intelligence
क्लिनिकली सर हम
assessment.
क्लिनिकली भी आप देख सकते हैं बच्चे
Right.
मदर भी रहेगी, बाकी सब चीज में इंटेलिजेंट है, बस ये बोलता ही नहीं है.
And a very important point you raised about the genetic testing for all. This is very, very important because I have seen evaluation of the patient with 30,000-40,000 rupees spending, but genetic testing microarray is not done. All the other tests, a lot of metabolic and battery of investigations, spending 30,000-40,000 package, but without doing microarray. So this is a very important point. And you said only 9% come out of the diagnosis if they are not given any treatment or given the treatment. 9% of the patients come out of that. Excellent talk, madam. So if there are any other questions, please people can unmute and interact. Over to Dr. Alka Agarwal.
Thank you very much, Dr. Praveen. I think these are the words of wisdom which came out from a person who has in-depth knowledge and vast experience of dealing with patients with autism. And theoretical agar hota hai, lekin the person who is in and out, day in and day out with such patients can give us the best responses and best, ideas or best knowledge about the thing. I think one of the most important, the chairpersons have summarized the condition very, very well, and after such a nice lecture from her. But I think one message that we should all carry home is that we should not label such children. हमारे पास भी आते हैं और हमें लगता है कि नहीं autism है, तो कम से कम we should take opinion from a person who is well versed with such a condition. And I'm sure even a developmental pediatrician will not label a patient so early. जब तक वो अच्छे से अपने आप convince नहीं हो जाता, जब तक नहीं, because till they've handed over the treatment plan, it is very, very distressing for the parents. And amongst the audience, I know there is a parent who is there, and that is why I can understand. The other thing is that this social interaction, I think, वो जन्म से ही शुरू हो जाता है, right from birth, like the eye contact and जो non-verbal cues होते हैं at the time of birth around 6 weeks. We can an experienced person will be able to, realize कि कुछ difference है. And that is why, though Dr. Praveen talked about a higher age of diagnosis, there is, on the other hand, on the other end of the spectrum, there is a lower age also, by doing a videographic examination, or from the videos which the mothers bring, the trained people who can diagnose autism can pick up the cases very early. And this is very important because, as Dr. Praveen mentioned, that earlier we diagnose, the better the prognosis of the child is. So other end of the spectrum is also equally important. And I congratulate Dr. Praveen for dealing with such a complex diagnostic entity as ASD, वो जितना बड़ा spectrum है उतना ही complex है, वो कभी-कभी ना तो clinically इतना समझ आता है, ना इतना there are no definite diagnostic criteria, then no definite treatment. We have to formulate customize the treatment plan to the patient. So I think very, very well handled.
And Dr. Alka, just to interrupt, there are also risk factors as well as concurring conditions. So it becomes more broad and
all the more complex. Bilkul.
And on the top of it, it is not a disease.
It is not a disease. Bilkul sahi keh rahe ho, Doctor. And एक important चीज, you have to merge these people, or you have to try and merge these people into the common society. क्योंकि वो भी otherwise तो वो अगर isolated रहे, then it will be a stigma for them as well as for the parents for altogether.
Very important point, Dr. Alka. I would say Dr. Praveen to comment on schooling. Can they be sent to normal school, and what and how is structured with they should be sent to normal school?
Sir, this as far as schooling is concerned, as I said, the children 9 to 10% children will outgrow, and 20 to 30% will change the diagnosis, like they'll have OCD or ADHD or simpler. So children who can go to, and the milder forms can go to the normal school, but majority of the children should go to an inclusive setup or an integrated setup. So inclusive setup is the setup where within the normal school, these children are included, but these are generally very, very mild cases. Then there is another type of schools available, which is called integrated schools, in which within a normal school premises, there is a separate section to handle these children where they can get a more of individualized services. So mild to moderate cases can go to those schools. Only severe cases and profound cases should go to the special schools.
Yeah, very true, Dr. Praveen. And with the burden that you are quoting, with the numbers which are increasing, we don't have sufficient hands, or we don't have sufficient experience.
I'm really scared, Dr. Alka. Actually, since the pandemic is over, I'm really scared to look at the number of patients which are pouring in. It's really.
You think the pandemic has increased the numbers, or do you think it is?
We cannot say it substantially, but in clinically, like I can feel the brunt. Like earlier, it never used to be so overwhelming. Now I don't know whether it is a backlog of 2 years, or is it actually, and now things have, telemedicine has also opened. So there is a lot of things. People are coming all across the globe. We had seen almost 46 country patients during pandemic time. So it has become overwhelming, cannot be handled just like that. So I think as a pediatrician, all of us should gear up and to provide services to such children. Very, very important.
And more importantly, if such children are handled by people who do not know the in-depth knowledge, like you mentioned, so many experimental therapies are being offered with promise of treatment. So I think will be another problem. So thank you very much, Dr. Praveen, for an excellent talk. And you opened up such a Pandora. Uske liye another 3 topics to kam se kam line up ho hi gaye hain, jisme we will keep inviting you. I just wanted to make one announcement for the benefit of the postgraduates, those who have joined in. So we are conducting this UP Pedicon on 19th, and it has been merged with the National Pedicon. And we invite papers and posters as well as the award papers for that day. And subsequent notices are also being sent to the HODs. So and we have received responses also, but we are expecting more. Especially all those students who have not enrolled themselves in the National Pedicon can still be a part of UP Pedicon on 19th by enrolling themselves or by registering themselves only for the UP Pedicon. So notices will be sent. It was just for the benefit of the faculty as well as the PGs who had joined. And one last word, that I really, really feel blessed to have been associated with this PG activity, and it has given me immense satisfaction that it could be of some use to our postgraduates and future of pediatrics. Thank you very much. Over to Dr. Shalabh.
Thank you, Dr. Alka, ma'am, for all your efforts which you put in for all around the year. We could have 21 very useful, fruitful sessions. I think this is a very good beginning in the first year. I think we look forward but this PG activity of the e-platform goes from strength, and it's really got a potential. I think the postgraduates, and not only the postgraduate, but also the practitioners as well as the faculty members, they are looking forward to it and praising it a lot. And I really thank once again, Dr. Praveen Suman for that wonderful talk. And as Dr. Alka said, that she is now due up for so many other discussions on this topic. We'll be looking forward to inviting her and look forward for her more presence and participation here. And I really thank once again, Dr. Sanjay Niranjan for his such enlightening summary and comments on this topic, and respected Dr. Ashok Rai sir, and all the faculty members from the UP State Medical Colleges, Dr. Om Chaurasia, Dr. Vijay Jaiswal, who have joined here, and senior pediatricians, practitioners, and all the postgraduates. And this is the last activity, as Dr. Alka ma'am told. And the next month, January, we'll not be having any activity, because that is the month for the National Pedicon, in which all the activities will be focused on that. And after that, the new team 2022, led by Dr. Alka ma'am, Dr. Sanjay Niranjan, Dr. Ajay Srivastava, is he there? Dr. Ajay Srivastava? Dr. Ajay?
Yes,
will be leading you, and we'll be continuing all this and the new energy and new vision of the new team. Thank you all. Thank you very much.
Thank you.
And thanks, Mr. Arun Sharma, for all the support that you give, the technical support for this, and all my co-ED and our team of the AOP UP. Thank you very much. Thank you, ma'am.
Thank you.
Thank you, Dr.
Alka.
Team 21.
Yeah.
Shalabh Agarwal, Alka Madam, Ajay Srivastava, hip hip hooray.